everybody. Good morning or good afternoon, wherever you are in the world this day. And thank you for joining us for this session of the webinar series organized by the Egyptian Committee of Pathology Training and Diagnexia. We are indeed very privileged to have with us today Professor Runjan Chetty, who is a very experienced anatomical pathologist in many parts of pathology, in fact, but with special interest in GI and pancreatic pathology. And he has held many chairs and distinguished positions in pathology departments in England, Scotland, and Northern America as well. He's also currently the Chief Medical Officer at Diagnexia, and I'm very grateful to him for not just sharing his time and his expertise, but also for really providing support for making this collaboration between the ECPT and Diagnexia happen. Runjan, thank you very much for being with us today, and over to you. We're looking forward to hear what you have to tell us about pancreatic pathology.
Thank you very much, man. It's a pleasure indeed. I think the talk was advertised as an approach to pancreatic biopsy, so I've taken the liberty of expanding it a little to include frozen sections, and I think they fit in quite nicely. So the scope of the talk today is I'm going to do an introduction to the types of pancreatic biopsies that you would encounter, and then an approach to the interpretation of these, some guiding principles that are basically in surgical pathology, whether it's biopsy or resection. Delve a little bit into the various pathologies that you will encounter, and then provide some clues and tips as to how best to approach reporting these. And then the final segment is an approach to pancreatic frozen sections. And the reason I have done it this way is that we've organized a specific webinar on pancreatic cytology by an expert from Spain, Professor Pepe Heffernan, and he's on course to do it in July. So that's a not to be missed session. He has a wonderful array of cases and is a brilliant teacher. So please do avail yourselves of that. Okay, so there are several means in which pancreatic biopsies are procured, and they are well recognized in their indications. So there are four main ones, and these are endoscopic ultrasound guided, either FNA or FNA fine needle biopsies, getting cores of tissue. But basically it is an endoscopic ultrasound guided retrieval of tissue. Now the advantage of FNA, and I'm not a cytopathologist, I stress, is that you have cytology smears and you have the ability to create a cell block which can provide tremendous amounts of information. Now the core biopsies in which I have got experience may be from a variety of techniques and pieces of equipment, and you get a core of a tissue from the lesion or the pancreas that the operator is looking at. And there are several other types as well. They're microforceps, which can actually bite into cyst walls and give you tissue there. You can aspirate cystic fluid and do the CEA levels, glucose, amylase, and indeed molecular studies on it. Less commonly seen these days are percutaneous biopsies. Again, you can do it as an FNA and the same cytology techniques would apply. And you can get a core needle biopsy, and that is akin to doing the histology. This is usually used in patients who have unresectable cancers or in which metastatic disease is suspected, and they just need a tissue diagnosis to commence treatment, be it curative or palliative, most likely palliative if it's unresectable. Then there's the transpapillary, that's through the papilla of the duodenum, usually done during ERCP, and there are several pieces of tissue and types of tissue that you can get here. Breast cytology of either pancreatic and bile ducts. You can use intraductal forceps and do a biopsy that way. You can aspirate pancreatic juice and bile and then do the cytology on that. And this is directed by the endoscopy at the time of cholangiopancreatoscopy. Now, intraoperative and surgical biopsies and tissue procurement is quite a separate entity to this, and hence I've tagged it in with frozen sections. And usually the patient is on the table, and they can then avail of a true cut or a wedge biopsy and take more tissue than the preceding 3 techniques would allow. And this is, of course, the setting for a frozen section or an intraoperative consultation. And I'd like to stress that it is a consultation between the pathologist and the surgeon. It is not a demand that we have to fulfill. It should be a collegial discussion as to what is exactly required and why they're doing it. So again, these can occur mostly when resection specimens are being done. And so there's almost an equivalent to if it's a resection specimen or an excision of part of a mass to relieve an obstruction, it's the same generation of tissue. And again, obviously, because we're getting more tissue, you can generate a definitive diagnosis. So with regard to the 2 modes, either cytology or histology, you can do brushings, you can actually get the fluid, you can do fine needle aspiration, whilst in histology you can generate cores either with forceps, and then if the patient is on the table, you can get akin to a surgical biopsy, so a considerable piece of tissue, which gives you the ability to assess it much easier. So I think when you're confronted with a slide, you need to know how the piece of tissue was taken. And because the way the tissue has been sampled really, as I say, sets the expectations for how you will assess the architecture, adequacy of the tissue, and then ancillary tests. And oftentimes, because tissue is limited, ancillary tests are often resorted to. As I mentioned previously, with a fine needle aspiration, you can either do straight cytology, you can create a cell block, and this is really excellent for confirming malignancy in solid masses. However, the limitation here is that the architecture is not quite apparent, and that can hinder interpretation. And of course, this procedure often can be corroborated with the rapid on-site evaluation. Now, fine needle biopsies, here the architecture and the stroma is preserved, and that gives the microscopist the ability to look at the epithelial cytology as well as the architecture and the stroma in which the epithelial structures are embedded. It allows you to actually do a full panel of immunohistochemistry. You can grade the lesion depending on how well it's represented. And of course, that tissue can be sent for molecular workup. And biopsies are usually the first line for many solid lesions. Least commonly used, as I mentioned, is the percutaneous core biopsy, and this can be CT guided or ultrasound guided and has a very specific indication where you just need a tissue diagnosis, basically, if they are going to employ any form of therapy. So they know what they're dealing with, whether it's a primary malignant pancreatic tumor or metastasis or whatever the clinical indication is.
Okay. Runjan, excuse me, sorry to interrupt, Runjan. Your headshot is slightly in the way of the right-hand side of the corner. So can I just direct you how to turn off your view or make yourself smaller? If you go into Webinar Kit, I can direct you. If you go to the cog, symbol, Runjan, it's on the top bar of Webinar Kit.
Yeah.
So show settings, the cog symbol.
I've got that, yeah.
And if you scroll down, there's a section, show corner camera input while sharing screens or slides. It's a toggle on or off. I think for now, maybe we can just toggle it off and see if that helps. Yes, so that will mean that you're unobstructed, unobstructing the slides. Perfect, that looks much better.
Okay, now I need to get the This is not working, Charlie.
If you go into your PowerPoint, it should work now. Yep.
Can you see it?
See you. Yep, okay. Perfect.
Okay. Okay, so like with any biopsy, whether it's from the GI tract or lung or breast, a systematic approach is the best, in my opinion. And that prevents you missing anything or not being aware of what is present on the slide. So if you look at it in a systematic fashion, that really does help you not make mistakes. Okay, but in particular, the pancreas warrants a systematic approach because tissue is often scant. There's a broad differential diagnosis despite the small size of the organ. And very importantly, reactive change, which occurs both in inflammatory lesions as well as malignant lesions, can mimic each other. And that's a really important differential, which I will delve into shortly. So a very disciplined, reproducible reading sequence is what I advocate, and it prevents an undercall or an overcall. And just remember that 90% of pancreatic lesions are solid and are invariably ductal adenocarcinomas. But just remember, whilst 90% of the time you'll be right, there are other diagnoses that one must consider. And so therefore always say, what else can it be? I advocate triaging it into solid versus cystic because they have very well-defined entities in both solid pancreatic lesions and cystic, and then neoplastic versus inflammatory. And we'll go through that in a minute. So it is basically a three-pillar approach of morphology, immunohistochemistry, and molecular, which ideally should be integrated. Oftentimes, morphology can be used in isolation if it is diagnostic. Many times we resort to immunohistochemistry to confirm what we see, and sometimes molecular when it is quite difficult. Now, I can't stress the importance of the clinical context, and I think when we did the esophagus, I also stressed the importance of clinical correlation and knowing what the endoscopist is seeing in the esophagus. Similarly, we need to know exactly what the clinical context is, what the clinical picture is, and very importantly, what the radiology is. Now, the pancreas is an organ where radiology is excellent, and in fact, in many cases can be diagnostic. So I think knowing what the radiology is before you examine the sample, knowing the clinical picture is really critical. So it goes without saying that you need to know the age and the clinical scenario of jaundice, weight loss, etc. in the individual. The radiology, as I said, it's very important to know whether it's solid or cystic, where the location is in the pancreas, whether it's duct dilatation, vascular contact communication with the duct system. All these inform your diagnostic impression. So the radiology, I think, is critical. Sometimes, if they've analyzed the serology in the fluid, you can have those levels, CA19-9 available, IgG4, again, depending on the clinical scenario. They can be very useful in helping you reach a diagnosis. But the most important thing when you are approaching a biopsy of the pancreas is, what is the clinical question? Why have they done it? What do they need? Is it to confirm malignancy? Is it to subtype a malignancy that's suspected on the radiology? Is it to exclude autoimmune pancreatitis, chronic pancreatitis, exclude malignancy? And so therefore we have a critical role in making a diagnosis before the patient has definitive surgery. Now, one of the things I should highlight here is that many cases now, especially of pancreatic cancers that are irresectable or borderline resectable, they're subjected to neoadjuvant chemoradiation. And that in itself induces changes in the pancreas. So when the pancreatectomy arrives and you start to look at the microscopy, just be aware of that background as well, because neoadjuvant chemoradiation induces cytologic and structural change in the pancreas of its own, and not to be confused with a cancer. So I advocate 5 basic steps in approaching pancreatic biopsy, and you just apply it uniformly, and as I said, it allows for reproducibility. You can defend it because you've gone through all the possible parameters, and of course, it prevents error, and I think that's, at the end of the day, what we want to do is no harm. So when you assess it, you look at the architecture. If, depending on the specimen type, as I mentioned previously, if the architecture is there, you should be able to say, well, is it cystic? Is it solid? Is it glandular, nested, papillary? Is it in sheets? Is there a relationship to ducts? All that will inform your impression under low magnification. And also there's a well-defined differential diagnosis that would fit those particular architectural patterns. Then to the cytology, clearly whether there's nucleotypia, mitoses, what does the cytoplasm look like? Does it contain abundant mucin creating vacuoles? Are there granules? Is there clearing? So the cytological features then are put together with the architecture. Now the stroma in the background is really quite important in the pancreas because desmoplasia is quite difficult to separate true cancer desmoplasia as from chronic pancreatitis. But hopefully I'll be able to show you some of the features that will help in some of the images that I'll show you. But at this juncture, let me say that the stroma that is associated with an infiltrating pancreatic cancer generally isn't as inflamed as the one you would see in chronic pancreatitis because of the different etiologies. So desmoplasia can be very useful and is, of course, useful. We know that mucinocystic neoplasms contain an ovarian type stroma, and that in itself is diagnostic. If you see those spindle cells and you decide, oh, well, I'll do a CD10 or a PR, and that confirms it, that is diagnostic in its own right. And then look for inflammation, necrosis, fibrosis. These are usually seen, as I said, in both neoplastic and non-neoplastic disease. Then you have the ability to do ancillary testing. So if you, at this stage, after step 3, can't make a diagnosis and you feel, well, I need to do immunohistochemistry to prove that it is an adenocarcinoma of the pancreas or a neuroendocrine tumor, well, you have the ability to do that. Again, if there's fluid available, you can test that as well, both from a chemical point of view as well as molecularly. And then having done those 4 steps, you then can sit down, having reviewed everything, including the clinical information, integrated, correlated, and issue a structured report. So it is important to have a logical sequence of integration when you formulate a report for the pancreas. So some pointers and tips. So before you commit to a diagnosis, make sure that you're dealing with lesional tissue. Distinguish a true lesion from adjacent normal acini, which sometimes when limited material is present can look funny. Islets in isolation can look a bit worrisome. And just remember that because of the technique of endoscopic ultrasound and the needle passing through, you can get duodenal tissue sometimes in the sample. So just be aware and don't make the error of saying it's an adenocarcinoma whilst it may be normal surface duodenal tissue. Again, small fragments of it. So in isolation, these can be misconstrued, and it's important to be aware of it. Then just remember, is there enough tissue for ancillary work? Remember, if you are dealing with cell blocks or even limited core biopsies, try and preserve material for ancillary testing. So don't order unnecessary immuno or deeper levels because ancillary tests may be the definitive test that will bail you out on that particular case. Again, where you have paired aspirates correlated with the rapid on-site results and what you see cytologically. And as I said, that will be discussed in July in more depth. And if at the end of the day you feel it is non-diagnostic, well, say it is non-diagnostic, and then say, well, what you would recommend. Another biopsy, correlate it with the imaging. But do not overcall. Do not be pushed into a corner and make a call that you're not confident with, that you can't stand behind, because at the end of the day, when the specimen is there, the pancreas is there, and you can't find a cancer or whatever you've been pressed into calling, there are obviously consequences. And again, bearing normal tissue structures that can be present in a biopsy, either through the technique or part of the biopsy tissue. Remember that when you are trying to distinguish small pieces of acinar tissue in a core biopsy, limited material, it tends to retain its lobularity, it's cohesive, the cytoplasm is more granular. And when you see that, it points away from adenocarcinoma. Adenocarcinoma is an irregular, unproliferated growth that is not well defined. Remember that the islets of Langerhans, again, can also look very, very suspicious in limited material, but they tend to be bland and again, very well sort of organized. But sometimes it can mimic a small cell carcinoma, or you can even miss a pancreatic neuroendocrine tumor, which may coexist. So just keep your wits about you when looking at the islets as well. I've already alluded to GI epithelium, either gastric or duodenal, being picked up by the needle and contaminating the tissue. So again, just be aware of that. And then reactive ductal atypia can occur in chronic pancreatitis, autoimmune pancreatitis. Just remember, don't overcall. I think it's better to err on the side of benignity than malignancy. Okay, so again, to contextualize your pathology report, it is part of the whole picture. It's not whilst the surgeons may tell you it is the sole arbiter of what it is, of what the diagnosis is and what happens to the patient, it is a very important facet, there's no doubt about it. But I think it is truly a multidisciplinary decision. And I think having a good working relationship with the radiologist and the surgeon, oncologist in charge of the patient, if there's any doubt, and having that full discussion really benefits the patient. Okay, so remember, it is assistive rather than a standalone item. I think I've alluded to, when you actually are writing the report, just state what the sample shows, the level of your diagnostic certainty, and the limits imposed by small sample size. Despite their best efforts, sometimes they give you scraps of tissue which are very difficult to interpret, and it's contaminated by mucus and bile, etc. And it really puts the pathologist under pressure. So when you feel that you are constrained in your ability to make a diagnosis, don't be forced into making a definitive diagnosis, and just describe what you see, especially where morphology is equivocal. Okay, and then say, well, I need another sample. Okay, so getting back to when you start to triage the case, you've got solid versus cystic. And it is well known that there's seven entities that present as solid masses. And clearly, ductal adenocarcinoma is the commonest, pancreatic neuroendocrine tumors, acinar cell carcinomas, solid papillary neoplasm, metastasis, lymphoma. And very interestingly, autoimmune pancreatitis can form a mass-forming lesion in the pancreas, and under radiological findings sometimes can be misconstrued as a cancer. And they do biopsies before the definitive operation, and you can't find anything. And then they do a frozen section at the time of pancreatectomy, and you still can't find anything. Just be aware that that can form a mass as well. And ideally, this should be discussed when you see the OR list and you are on for a frozen section. Quickly check the clinical notes, the imaging, and if you can contact them before they send you the piece of tissue, raise the issue that, well, the previous results suggest that it could be just fibrous tissue, not a tumor. Cystic lesions are well recognized: IPMN, mucinous cystic neoplasm, as I said, subtended by ovarian type stroma, serous adenocarcinoma with its clear cells, and then pseudocysts, a history of alcohol abuse. And then cystic change can occur in some solid tumors. Of course, it can occur in ductal adenocarcinoma, it can occur in a neuroendocrine tumor, and in a solid pseudopapillary tumor. So again, just be aware that cystic lesions aren't necessarily non-solid lesions that can have a cystic component. Okay, so ductal adenocarcinoma is the one that is most frequently biopsied, and you will see. Now, the morphology here in the obvious case is quite easy, and I have to go through that. And generally speaking, the ones that put you under pressure are the ones that don't fulfill all the obvious criteria. But if you see irregularly spaced, incomplete, angulated glands, and I'll show you some images later, infiltrating into a desmoplastic stroma, that is not going to be chronic pancreatitis. When the glands are aberrantly placed, and that's the best way I can describe it, is you've got this atypical looking gland stuck next to a muscular vessel within a nerve, perineural invasion, and isolated glands stuck in fat. That's not normal for chronic pancreatitis. That is cancer. Now, I'll tell you one thing. When you really need perineural invasion in a biopsy and limited material, you're never going to find it. That's just the way it is, unfortunately. But yes, in a fully fledged case, perineural invasion clearly will help you. But just examine the glands that are in a perineural locale, because I'll mention this later, chronic pancreatitis does some funny things as well. Then look at the cytology, and this is the key feature for me always has been the nuclear size variation. I don't worry so much about whether they're mitoses, but if in a gland the nuclei show pleomorphism and they're large, and usually the size variation is 4:1 compared to a normal gland within the gland in question. The glands are, the nuclei are at different levels. They show loss of polarity and then prominent nucleoli. And if the ductular structure has attendant luminal necrotic debris, you're pretty certain that is a malignant gland. Okay, so be careful that in well-differentiated pancreatic ductal adenocarcinomas, you can get reactive changes stuck in it. And sometimes the glands, even in the cancer, are exquisitely well-differentiated. So look for the other features that I've mentioned, the nuclear size variation. So if you get hyperchromatic, pleomorphic nuclei with big nucleoli, no matter how well formed the gland is, that pushes you to adenocarcinoma. You can do a variety of molecular and immunohistochemical adjunctive tests to help you, and I've just listed them there. But generally speaking, you can make the diagnosis on morphology with limited use of molecular and immunohistochemistry, especially in limited material. Okay, so neuroendocrine tumors, sometimes they are unrecognized and can be present with a pancreatic ductal adenocarcinoma or mimicking an actual adenocarcinoma. Again, here the cytological features are really important. The cells are very uniform in appearance and have this salt and pepper chromatin distribution. The pattern is very organized and typically nested, and you can get a trabecular pattern as well. And if you then feel that you need to resort to immunohistochemistry, they really work well with at least two of the three that I've recommended there. Generally, don't do one stain because it depends on the size of the neuroendocrine granules, so you can get a very weak synaptophysin staining and then be misled, whilst if you had done a synapto and a chromogranin, the chromogranin A would light up like a Christmas tree. And if you have the enough tissue, you can suggest a grade. Now remember, core biopsy is not representative of the entire lesion, but in some centers, the clinicians like to have an indication of the grade, especially if it's already high on a needle biopsy, for instance. So you can do Ki67 and count the mitoses if you have enough tissue there, and those are the WHO grading, especially for well-differentiated. Okay, now having checked the radiology and you know that it's a cystic lesion that's coming your way, they are well characterized cystic lesions with well recognized morphological features, and I've listed them there. Just to remember that on a small mucinous sample, low cellularity, you can't grade a mucinous cystic neoplasm or an IPMN because of the limited sampling. So grade on what you see. I generally write a caveat to say on the material that is sampled, this is low grade. However, other areas may show more severe grades and or invasion. So I think just caveat that as well, because sometimes reports are taken on face value and they're not interrogated properly, and they say, oh, well, you called it low grade, and in the meantime there's infiltration elsewhere and it's an adenocarcinoma. So protect yourself. Okay, so the very important thing here, and this is where pathologists earn their crust, those who deal with pancreases, is that inflammatory disease can mimic cancer, and this is well recognized. And as I said, a mass-forming pancreatitis can look exactly like a cancer radiologically, especially autoimmune pancreatitis. So if radiologically it's suspected that it is a carcinoma, and preoperative attempts at diagnosis tissue diagnosis have not been successful, and they take the patient to the table, they'll do a frozen section. And this is, again, where you really have to be aware that this can mimic a malignancy. And so if you don't see anything suggested to them, and they may send you more tissue before doing a definitive removal of the pancreas. Sometimes they just ignore you and remove the pancreas, and then you have to sample the entire pancreas looking for the clinical cancer that they have diagnosed. Now, when you get chronic pancreatitis, because of the fibrosis, there's atrophy, and therefore the glands and the ducts are broken up by fibrous tissue. But in general, if you go on low power, and always start on low power, it tends to retain its lobularity. And whilst there may be disruption of acini by fibrous bands intersecting the acini, causing atrophy, they tend to be a bit organized. So again, the low power view will be very important in formulating your opinion. Now, reactive ductal atypia and cells have every reason to react to inflammation and show nucleomegaly, and can show nucleoli, and can show mitotic activity. But generally speaking, all the features that are described in an adenocarcinoma, and I will enumerate them later on as well, just for clarity, are not seen in chronic pancreatitis, or if some of the features are seen, not to the extent that you would see in an adenocarcinoma. And generally, you will see the glands are somewhat well differentiated, whilst there may be a degree of loss of polarity. It's really still confined to the lower part of the cell. And very importantly, you don't get these aberrant glands stuck in the middle of fat with nothing around it, especially if they are irregularly shaped or next to a large vessel. So if you see these single glands not accompanied by anything, with no intervening acini tissue between, say, a vessel and the gland, be suspicious for adenocarcinoma. And if that is all you have, then you would suggest a diagnosis of adenocarcinoma, because in general, chronic pancreatitis does not give you single atypical appearing ducts in aberrant locations. Again, you can do some immunohistochemistry in this setting, and those ducts do not show mutant p53 expression, and SMAD4 is generally retained. Now, this interesting entity of autoimmune pancreatitis, two types, a type 1 being the prototype for IgG4, and it is attended by some three classical features. You get this storiform type fibrosis, obliterative phlebitis, and a dense lymphoplasmacytic infiltrate, often accompanied by eosinophils. And you have great swathes of this fibrosis and inflammation, and you don't see ductular structures. You don't see anything worrying from an epithelial point of view. And then when you start to think about that, you do an IgG4, and you do an IgG as well, do the ratios, and then you can even check the serology. So it spawns the diagnosis of an IgG4 related disease rather than an IgG4 autoimmune disease. And that has a constellation of other clinical features that the clinicians put together. So your suspicion is also heightened if the patient has autoimmune diseases in other sites as well. Type 2 is really uncommon. I think I've only seen about 2 or 3 cases of this, and here you have neutrophils instead of chronic inflammatory cells. And again, the damage tends to be around the duct, so it's ductulocentric. And IgG4 in type 2 IgG4 is not particularly increased. This particular variant of autoimmune pancreatitis is strongly associated with inflammatory bowel diseases. Somewhat uncommon. Okay, ancillary studies. I'm a great believer in morphology, but certainly I will never ignore the role of ancillary studies in helping me make a diagnosis. I've alluded to several of the immunohistochemical stains already, and you can resort to them depending on your index of suspicion or your differential diagnosis. Molecular testing is available in many centers, and if you're in doubt, I would strongly advocate using it. Cyst fluid chemistry is useful. It's just an indication. It's not diagnostic of its own right, but you take that in conjunction with the cytological features if you've got an aspirate done, and if you want to do molecular as well. So if you don't have the benefit of morphology and all you have is a bit of fluid, and you've got the chemistry, you've got some cytological preparations, well, then you can do molecular studies on the fluid. Okay, in summary, I think one needs to know about the chestnut of reactive versus malignant. I think we have flogged that, and we know exactly that these are the two major considerations. Remember, if you get islets entrapped, but by the same token, don't forget that you can get neuroendocrine tumors as well. Again, depending on where the radiological lesion is, you can correlate what you see with the radiology. Remember about contamination of epithelium from other sites. And very importantly, if you've got small samples, just recognize the limitations that the small sample provides, that you cannot overcommit, and stay within the limits of your discretion. Okay, so frame the case, read it in a fixed sequence that is reproducible, repeatable, prevents you from missing anything. Apply a focused panel based on your morphological impression. Don't just do a widespread immunohistochemical panel to bail you out because you don't know what it is. It should always be focused and directed. And report exactly what you see. Okay, so remember that the biopsy is only an important part of the decision-making tree, but it should never alone make the diagnosis unless it is obvious and diagnostic. So here's some examples of material that we get from the biopsies that are done through ultrasound. And of course, they're just pictures, and these are substantial bits of tissue which enable a diagnosis. And this bears out what I was saying, is that you've got a fibrous stroma, or desmoplasia if you like, and then you've got ducts that are embedded within it. They are desultory inflammatory cells strewn throughout it focally. Now, if this was chronic pancreatitis, this could be very much in keeping with the stroma that you see with it because there's inflammation, but generally you get a bit more inflammation. But the key here is the distribution of the ducts. They are irregularly and haphazardly arranged. None of these four look alike. And when you get these angulated ducts with poorly formed lumina, that is a dead giveaway for a pancreatic adenocarcinoma. And if you look very carefully, you'll see that the cytoplasm in this particular duct is clear, and it has this foamy appearance, very characteristic, again, of a pancreatic adenocarcinoma. And if you're lucky in some cases, you'll see that the nuclear features over and above what I've described as nucleomegaly, hyperchromasia, loss of stratification, mitotic figures, nucleoli, you may see an irregular nuclear outline imparting this raisinoid appearance to the nuclei. Again, a very key feature for pancreatic adenocarcinoma. Okay, so better differentiated ducts here. But again, in isolation, could this be chronic pancreatitis with widespread atrophy of the acinar tissue? In isolation, those two, probably not, because you've got hyperchromasia, nucleomegaly, irregularity of the shape. These two ducts here are pretty diagnostic, in my opinion. And here it is seen in another area. You've got the similar ductular structures with cytoplasmic vacuoles and mucin. And this irregularity, single cells, misformed glands, teardrop-shaped glands, or angulated, sharp-edged glands, single cells, two cells coalescing there, again single cells, that's diagnostic for pancreatic adenocarcinoma. And I'll come back to this particular image later on. Okay, more tissue here. Again, lots of stroma, lots of blood, bit of mucin, and then some epithelial elements entrapped here, and here it is under high magnification. Well-formed papillary structures, clearly mucin-producing glands, nuclear atypia, bit of hyperchromasia, nucleoli, pseudostratification, low-grade dysplastic features. And this happened to be from a introductive papillary mucinous neoplasm. And here you can say what it is, what the diagnosis is. You've confirmed that because you know it's a cystic lesion on the radiology, and on the material that you've got, it is low grade. And then you caveat that by saying other areas may show worse features. Okay, so let's shift gears slightly. We've got just a few minutes to do frozen sections of the pancreas. This is challenging, and I was fortunate enough to work in a center where we had pancreatic frozen sections almost every day, and therefore you develop the experience and the expertise because you are exposed to it. And I think that's a very important aspect to dealing with frozen sections of the pancreas. If you do one every 5 years, don't do it. Get somebody else to do it. Otherwise, you're putting yourself in an invidious position. Hampered by small tissue size, and then frozen section artifact is a bugbear. Remember, I was saying that more and more cases are having preoperative neoadjuvant chemoradiation, and this induces changes such as fibrosis in the stroma, bizarre appearing epithelial nuclei, and can look horrendous on a frozen section. And then the ever-present chronic pancreatitis mimicking adenocarcinoma. Now, just some important facts just to show you and contextualize how different frozen sections of the pancreas are as compared to any other frozen section from another system, is that more pancreatic frozen sections are deferred to paraffin-embedded tissue than in the general milieu, where only 2 to 3% are. Up to 10% of pancreatic frozen sections, the report is defer to permanent sections. And that is acceptable because you do not want to overcommit. So just remember that the advice that I gave about deferring or not committing is widely accepted in a variety of institutions where they do pancreatic frozen sections. And importantly, because of all these issues that I've described, the discordance rate between a pancreas frozen section and the permanent section is up to 5%. Generally, in other frozen section scenarios, it's really around the 1% to 2% mark, again, depending on what you're being asked to look at. But generally, margins are what frozen sections are all about. And in lung and in breast and in wherever else you're asked to do it, in the rest of the GI tract, it's pretty clear cut because it's going to be normal. So therefore, the discrepancy rate for pancreatic frozen sections is a magnitude higher than anywhere else. So that just contextualizes the whole scenario of frozen sections of the pancreas. Now, what are the indications? An indication for a frozen section, whether it's from the pancreas or anywhere, should never be curiosity driven. Oh, I want to know what it is, so when the patient wakes up, I can tell them what it is. That is not an indication for a frozen section. Pertinent to the pancreas, it's usually margins, and I'll show you which margins are important. And at this point, you have a frozen section margin, which you get, and depending on what you tell the surgeon, he will then revise it, and therefore the specimen margin will be the final margin or the true margin. So always correlate the frozen section margin with the specimen margin in your report. Otherwise, you'll get a call from the surgeon to say, oh, but the frozen section said there was cancer at the frozen section margin, but you've reported the pancreatectomy, and in the margin section, you said it's free of tumor. So always correlate that, because remember, it doesn't necessarily correlate with the final specimen margin. That's really important. Otherwise, your colleagues are going to look a bit foolish. Okay, rarely should a frozen section for the pancreas be to establish a primary diagnosis. Given the multiple parameters and biopsy options that I mentioned earlier, they usually resort to that. Very rarely, unless there's some emergency that has precipitated the operation, will you be asked to make a diagnosis. And usually, if it is an emergency, then the tumor will be widely spread. The other reason why you may get a frozen in the pancreas is to exclude a metastasis. So if the patient has the clinical picture of preceding history of a melanoma or a renal cell cancer, and now presents with a pancreatic mass, and they want to know whether it's a primary or a secondary, that's of use. Okay. Again, frozen sections in the pancreas are usually pre-planned, so because the patient is on the operating list, so you will have the opportunity to see the patient's previous biopsies, imaging, as I said, and history. So try and prepare yourself before you get the frozen section as much as possible, rather than saying, right, bring it and let me see what it is. I think that's where you run into difficulty. Okay, just to refresh one's memory, I love doing the anatomy of the pancreas. I just find it fascinating. So this is the anterior view. And so if you know the anatomy, then you'll know how the Whipple's operations are done. So just to orientate, you know that you've got the four regions, and then you've got this uncinate process here, which is the groove through which the mesenteric vessels run. And therefore, when you appreciate the anatomy, then when you see the various parts of it that are taken for margins, it makes sense. And then, so when they proceed with the Whipples, what they do is they will transect the pancreas there, depending on where the tumor is, of course, and we're usually in that location, and then they'll leave the remainder. And so this, of course, and that is a critical margin, that's a margin, and then if the biliary gallbladder is included, then the biliary margin is important. So here it is. So you've got the duodenal loop that has been taken out with the head of the pancreas. So the proximal and distal margins will be important. So this is assuming now you've got the specimen and they have not done frozen sections at the time of the operation. Sometimes they will. They'll give it to you. The surgeons will send these separately. If not, and you get the specimen fresh, then these are the margins you've got to take. The cystic duct margin, and then the transected pancreatic margins. So always ink and use your uniform ink colors, so you know where the posterior aspect is, you know where the vascular groove is, and that's why I emphasized where the vessels grow. And that is a very critical margin, the posterior margin or retroperitoneal margin. And remember, the anterior bit of the slice that you take is a surface, it's not a margin. Okay, and this is the posterior aspect of it. So be aware of what you're looking at. Okay, so if I want to elaborate on the morphological features that help you make a diagnosis of adenocarcinoma. There are three primary ones, or major criteria, if you like, and it's the nuclear size, which is increased. There's marked variation in nuclear appearance. I've mentioned that. Incomplete lumina, so they are either obliterated or angulated or teardrop shaped. And when you get these irregularly shaped glands rather than nice, smooth, round ducts, heightened index of suspicion for adenocarcinoma. And then, replete with that, you have haphazard distribution of ductular structures and glands, no evidence or suggestion of a lobularity to it. Think adenocarcinoma. Perineural invasion, as I said, when it's there, great. Invariably, it's not going to be there to bail you out. And just remember, in chronic pancreatitis, there are reports and publications where they have said that you can get perineural invasion of ductular structures. And I'll come back to that. Necrotic luminal debris, reflective of increased turnover, stromal desmoplasia, which can be tricky, separating it from chronic pancreatitis, mitotic activity increased, big nucleoli, single cell infiltration, glands in odd places, cribriforming of the glands. All those help formulate a diagnosis of adenocarcinoma. So there's several criteria. There are 3 major and 8 minor criteria, but you put the constellation of all these features together, most of the time you will be able to make a morphological diagnosis. If you can't, then resort to ancillary testing. Also, show it to a colleague. Okay, just bringing you back to the image I showed you, and this really highlights these preceding features. In fact, the only thing that I think is the cribriforming and the odd-placed gland are not seen in these images. So this is really full house here. Okay, so I've talked a lot about separation from chronic pancreatitis. So, in practical terms, what does this mean? Well, none of the features that I've described that are in keeping or diagnostic for adenocarcinoma should be present for chronic pancreatitis. But there's a degree of overlap, but it's not as severe. It's not as florid. Okay, so just remember that you will get some atopia, you will get some nuclear pleomorphism and hypochromasia, but not as much as you would expect in an adenocarcinoma. And this is where experience counts. So if you've never seen a chronic pancreatitis and you've never seen an adenocarcinoma, and this is your first case of a pancreas frozen section, and you're confronted with this dilemma, then call for help. Do not be forced into making a diagnosis. And then once you have established it's either chronic pancreatitis or adenocarcinoma, you build on that experience. You learn from the case. Okay? In chronic pancreatitis, oftentimes you have prominence of the islets. And the reason is you have acinar atrophy and fibrosis, but the islets survive. And that's because the acinar tissue is exquisitively sensitive to fibrosis and ischemia, whilst the islets tend to survive more. And as a result of that, they look a lot more prominent. They're more frequent because you've now got fibrosis and you've got rounded aggregates of islets of Langerhans present. And they too can show a degree of hyperplasia and hypertrophy and some nucleatypia. Again, you generally will have lobules and islets that are well sort of formed, which will separate it from a neuroendocrine tumor. And they vary in size as well. You can get small islets and big islets as well in the setting of chronic pancreatitis. So again, if there's been no mass present and you see this, then it is reactive surviving islets of Langerhans. Now, I've mentioned this already, in chronic pancreatitis, because of the fibrosis pushing ductular structures, obliterating and causing atrophy of acini, ductular structures can get squeezed into the perineural sheath. And under low magnification, you see a nerve, and within the perineural space, you see a ductular structure. Immediately, you will diagnose adenocarcinoma. Yes, you will be right in most instances, but think again. Look at the morphology of those glands. Look at the cytology of those ducts that are in a perineural locale. If they do not fulfill the criteria for adenocarcinoma to the extent that I've described, remember, in chronic pancreatitis, you can get benign appearing reactive ducts compressed into nerves. So just be careful of that. When you're looking at the case as well, be aware of unusual variants of adenocarcinoma. You can get, a foamy cell and a variety of others. Remember that pancreatic neuroendocrine tumors can have a ductular ectatic variant, which you have large ectatic ducts present within the neuroendocrine tumor, and on frozen section can simulate an infiltrating adenocarcinoma. I've seen about 5 or 6 of these. Remember, other primary diagnoses other than adenocarcinoma occurs, right? And then 2 pathologies. So you can get a pancreatic adenocarcinoma and a pancreatic neuroendocrine tumor. You can get chronic pancreatitis, and you can also get adenocarcinoma. So you can get coexistence of multiple pathologies. Don't get cornered into one diagnosis. And remember, metastasis, even if clinically unsuspected, I've seen cases where the pancreas frozen section came in as query adenocarcinoma pancreas, and it turned out to be a metastatic melanoma. So again, Knowing the clinical history helps. In this particular case that I mentioned, there was no history of a melanoma. The patient had a melanoma removed 25 years previously. So renal cell carcinoma is another one that can present late as a metastasis as well. So just remember that. If the morphology doesn't fit, think outside of the box. Okay, I'm going to end with some images of frozen sections. And here is one where you have some islets and you have atrophic acinar tissue. But the essence here is the low power impression of lobularity. And you do not see single isolated ducts wandering around that are irregularly shaped. And under this magnification, it's chronic pancreatitis. Okay. And then you start to look around and you see, ooh, there's a duct there, and there's a large vessel here with an elastic layer, and it's sort of muscular. And then you've got some remnants of acinar tissue there, and you've got this duct, which is sort of surrounded by some fibrous tissue. So what do you say here? Is this adenocarcinoma, or is this chronic pancreatitis? So these are the real live situations, and I'm just showing you areas that you will sometimes get as the only representation of the lesion. And this actually is a pancreatic adenocarcinoma, because if you start to look really carefully here, you're beginning, despite the frozen artifact, you're starting to see nucleomegaly, pleomorphism, a degree of luminal debris. And as I said, when you get an isolated odd gland next to a vessel, your index of suspicion for adenocarcinoma is heightened. This is a higher power of the same. Again, you'll appreciate the nuclear features and a bit of debris. So these images are from a book that my colleagues and I are about to publish with Cambridge University Press. So I've borrowed them from Doctors Deshpande and others who are collaborators with me in this textbook on practical diagnostic pathology and cytopathology of the pancreatic or biliary tract. Okay, here's another frozen section, actually a very good frozen section. Again, highlighting atrophy, chronic inflammation, but again, you'll see surviving ducts that look a little angry at this magnification. But look, it's respecting the stroma, it's respecting its relationship to acini, non-infiltrative, despite the nuclear hyperchromasia. It's well formed. It's a little distorted, but still it's well formed. Chronic pancreatitis. And this is another example of frozen section. Bottom left here, you've got acinar tissue, and then you've got these very atypical single cells in association with the cells that look very much like it in the duct as well. So this is a slightly easier example, a bit of debris and dying cells in there. Okay, here's an example of glands that are very close to a nerve. It's probably in another level was very in the perineural space. Again, if you look at architecture, you look at cytology, these are not normal glands. You've got single cells, in fact, a mitotic figure or two. And again, very much in keeping with adenocarcinoma. Okay, another example, lots of atrophy, and you've got single glands here, and you've got islets there and islets there, and you see how the islets have survived in contrast to the acinar tissue. Still looking reasonably pristine and intact. And you then say, oh, this is a large duct, but look at the relationship with normal structures. So it's equidistant, it's non-infiltrative, and therefore you start to examine that carefully and then look for more evidence. So don't only base it on one feature. This is another biopsy from IPMN. This is really nice tissue that was sampled at the time of surgery, actually. The frozen section is pretty readable as you would in a paraffin-embedded tissue. Okay, so let me wind up by saying, what are the take-home points, right? Keep the clinical picture in mind, especially the radiology. Know what type of biopsy it is and therefore the kind of material you're getting. Be aware of the spectrum of pathologies that can be encountered. Dual pathology, very important. Frozen sections, experience is really important, and expertise. So before you embark on one, know what the exact question is that you are answering. If you are hard-pressed to make a diagnosis, ask for more tissue. If you are still stuck, ask a colleague. And if all else fails, defer to paraffin sections. And that is an accepted mode of operation. And remember, when you do finally report the case, correlate the frozen section margin with the final resection margin status, and look at the cytology as well. Okay. Thank you very much. Happy to take questions, Mona.
Runjan, thank you very much for a very well-rounded talk about the topic, and you've really portrayed how important it is that we approach biopsies well informed, but also keeping a very open mind and with strong potential to thinking outside the box. I'm not seeing questions showing up in the chat yet from our colleagues attending the talk, so I will just ask you a couple of questions, if I may, until we get more questions. All the points you raised about frozen sections are really most helpful. And I wanted to ask you, do you have, where you practiced, do you have a certain protocol at requirements that the surgeons include in the request form and pre-information to the lab prior to submission of the specimens, or do you just get a phone call and say, we've received a frozen section on a pancreatic?
The answer is that is yes. We do have a pro forma that they're supposed to fill. They never did. Often, because we worked as a GI pancreas site group specific, they'd give you a call, or you'd know from the operating list if you were on frozen sections that it was coming, or your colleague would call you down. So we would then know that we're expecting frozen section. We either have some information or communication from the surgical team, or we don't, and then we make the necessary steps of trying to acquire some information. But yes, we do have a pro forma, for the indications, radiological features, and it was, I don't think, filled more than 3 or 4 times, sadly.
Great. My other question is, in situations where there is a discrepancy between the cytological diagnosis and the histological diagnosis, how do you address that?
Okay, so I don't want to offend any pathologists and cytologists, is that the final, tissue sections really take precedence. And if they've overcalled, I think, and I don't want to speak for Pepe, who will do the talk next week, but there is a discordance in what they see cytologically in terms of grade compared to what we see on the histological sections. So it is recognized that happens, and what we used to do is correlate it with them, and of course that's just taken in as a learning and the way it is. But the discrepancies between cytology and the histology are not infrequent.
Right, I've got a question here from one of our colleagues asking about single cells and pancreatic cores and how to judge them, asking whether you always, or you think these always mean adenocarcinoma more than pancreatitis.
No, I mean, no one finding in isolation, should be taken into account. But generally speaking, if you've got single cells, then have a look at them, because remember, you can get atrophic acini, and the atrophic islets and the endocrine cells can look single file and infiltrative as well. So examine the cytology. So if you have single cells embedded within a fibrous stroma, take a look at the nuclear features. So nucleomegaly, hyperchromasia are very key features. And then if no 2 nuclei look alike in that stream of single cells, that indicates adenocarcinoma. But again, if the cells are uniform, then I would not on that alone diagnose adenocarcinoma. I'll start to look around for other features, or if I don't have them, I'll ask for more tissue.
Brilliant. Well, I'm conscious that unfortunately we have reached the full hour and actually running over a few minutes. There don't seem to be more questions in the chat, but there's a plethora of expression of appreciation to the great talk.
My pleasure.
And many thanks to you, Runjan, from everyone who's joined us, and indeed from myself and the Egyptian Committee for Pathology Training. And thank you also to Charlie Ann and the admin team at Diagnexia, who are doing a great job to make sure we can deliver these fantastic tutorials. Thank you, Runjan, and thank you all attending with us this afternoon, and see you soon next time.
Thank you, Mona. Thank you.
Thank you both.
Thank you.